Well, thank you for having me. I've been working with Dr. Shidlow and the Heterotaxy team at Boston Children's Hospital for about a few years now, and definitely learning a lot of things, and it's really an honor to be a part of the team. So my goal today is to talk about immunologic assessment in heterotaxy syndromes. So to start off, I have no conflicts of interest to disclose. But the main concern that we have as immunologists is there a spleen or not? And if there is, what is the function of the spleen? So that is the central concern that we have, and then everything else beyond that, is probably less complicated, but really what we want to establish is presence of functioning spleen or not, because having hyposplenism or asplenia really sets patients up for severe, overwhelming infection. So, we've talked about all the amazing things that these patients go through, and what we're trying to do as immunologists is minimize the risk of infection in these complicated patients. And any kind of even subtle immune deficiencies can just add to their risk. So it's really important for us to understand their immunologic function. So we assess the presence and function of spleen, and we'll go over that in greater detail, and then we will monitor their immunologic status over time because that changes in these patients from year to year. So keeping a close eye on them, I think, is really important for minimizing their infectious risk. So just to kind of go over asplenia, it's estimated that there's about 1 million people in the U.S. who are asplenic or hyposplenic, but as we'll see in the next slide, that's probably an underestimation. But common causes of asplenia include trauma and subsequent surgical removal. There can be therapeutic reasons to remove the spleen, hereditary spherocytosis, or autoimmune conditions such as ITP and autoimmune hemolytic anemia that are resistant to treatment. And then, of course, patients with sickle cell disease undergo autoinfarction, so they lose splenic function over time. The less common causes are isolated congenital asplenia, and then, of course, of interest to our group is heterotaxy syndrome. So this slide just shows the many different causes of asplenia and hyposplenism. In our situation, we're interested in Ivermark syndrome, but there are many causes of hyposplenism, and that can include a variety of gastrointestinal diseases, liver diseases, a number of hematologic and oncologic conditions, and then a number of immune deficiencies and immune dysregulation syndromes, infectious diseases. So you can see that there are a lot of different causes for impaired splenic function, and it's probably something that's not evaluated as frequently as would be helpful. So impaired splenic function leads to increased amounts of these cells within the circulation. These are pitted red blood cells. And those pits that you see are actually precipitates of misfolded or defective protein, mostly hemoglobin within the red blood cell. You can also get buildup of other different bodies, one of them being Howell-Jolly bodies, which are remnants of DNA and nuclear remnants that can build up in patients with impaired splenic function. So in heterotaxy, as has already been discussed, the presence or absence of spleen tends to be associated with left versus right isomerism. So left isomerism is also referred to as polysplenia syndrome and is characterized by bilateral left atria 2 bilobed lungs, and then multiple spleens. And the question is, are those spleens functioning in a normal fashion? And then right isomerism is associated with asplenia, bilateral right atria, 2 trilobed lungs, asplenia, and typically more severe cardiovascular malformations. Although in our discussions in our monthly heterotaxy meetings, there can be a lot of variability in the presence of heterotaxy. So spleen, it's important to understand the importance of the spleen to the immune system. So it is the largest lymphoid organ in the body. Other lymphoid organs that you would be familiar with would be lymph nodes. But the function of the spleen is to filter the blood, and it filters out damaged or old blood cells, and it also filters pathogens from the circulatory system. The spleen is also the site of immune responses to these pathogens through both innate and adaptive immune system. So broadly speaking, let's see, does the arrow show up? Well, so you'll see in this upper right-hand corner, the venous sinusoids of the red pulp. This is where the blood is filtered. And there are numerous macrophages, cords and sinuses that the blood filters through. The channels that the blood filters through are very small, usually narrower than the width of a red blood cell. So cells that have these pits or Hal-Jolly bodies have a difficult time getting through because the pits are actually not easily deformed, so they wind up getting plucked out as the cells traverse these cords, and then the membrane reanneals, and then you're left with normal red blood cells. The older senescent red blood cells will express a molecule called phosphatidylserine, and that's a marker for removal by macrophages. So that's how the red pulp works. The white pulp, shown down here in the middle, consists of T lymphocytes and B lymphocytes as well as dendritic cells, and that's the site where the adaptive immune responses occur. So all of that blood filters through the spleen, and that allows the immune system to survey the blood for the presence of pathogens. If different pathogens are detected, then you'll get development of specific antibodies against those pathogens, which are highly specific and help to clear infections. So initially, you'll get blood coming in through the red pulp. The macrophages will clear some of the pathogens as best they can. Anything that persists, then the adaptive response of the white pulp then helps to clear the infection later on. The key thing about the adaptive immune response is that it takes a week or two for it to happen. And the interesting part of the spleen are these zones called the marginal zone, or MZ. That's where a specialized class of B lymphocyte resides. These are known as the IgM-positive memory B cells. And what makes them unique is that they produce IgM antibodies that recognize the polysaccharides of encapsulated organisms like Neisseria and pneumococcus. And these can be produced very quickly and help protect the individual from overwhelming infection from some of these encapsulated organisms. So the consequence of asplenia or hyposplenia is overwhelming sepsis due to these encapsulated organisms such as strep pneumonia, Haemophilus influenza type B, and Neisseria meningitidis. The reason that encapsulated bacteria are so dangerous is that that capsule actually protects them from complement activation, and they are not easily engulfed by the bacteria. So if you lack a spleen, then you're not going to be able to produce that IgM that binds to those capsules and activates the complement, allowing the macrophages to engulf them. And strep pneumonia accounts for 90% of overwhelming sepsis in these patients, followed by Haemophilus influenza type B. But there are other microorganisms that are also dangerous to these patients, including Pseudomonas, Capnophagia, and Bartonella. And it's important for families to understand that Capnophagia and Bartonella are actually part of the oral flora of dogs and cats. So having pets in the home does put them at somewhat higher risk. If they get bitten by the pet, they need to seek medical attention very quickly because that can lead to overwhelming infection. The incidence of fulminant sepsis is estimated to be as high as 7%, but the mortality from sepsis in these patients is up to 70%, so it's important that they be evaluated quickly. The groups that are at highest risk are children who are less than 3 years of age and older adults greater than 60 years of age. So how do we evaluate for spleen and spleen function? Well, the first thing, of course, is reviewing the abdominal imaging from these patients, whether that be from CT scans or ultrasounds, looking for the presence or absence of splenic tissue. One of the more common ways a number of years ago was to look for Howell-Jolly bodies in peripheral blood smears. The downside to that is that it's not very sensitive, so we've moved more towards pitted red cell counts, which is a much more sensitive assay for hyposplenism. And that is accomplished using interference microscopy. And then the other gold standard that we use is assessing for those IgM memory B cells, which are part of the white pulp. So the combination of the pitted red cell count and assessing the IgM memory B cells is really what we're basing our assessment of splenic function on. There are now other options for this analysis, including flow-based quantitation of Howell-Jolly bodies, and you can send that to the Medical College of Wisconsin, and that's probably every bit as good, if not a bit more sensitive than even the pitted red cell count. And Boston Children's Hospital actually will be doing this assay probably starting in the spring of 2026. So the pitted red cell count, again, that's an assessment of red pulp function. Typically in healthy individuals, the pit count is less than 4%. Counts greater than 4% is considered indicative of hyposplenism, and typically values around 14 to 15% are what you might find in patients who are asplenic. So it's a pretty simple test to order, 3 mLs of blood sent to Cincinnati Children's Hospital, and we found it to be a very quick and reliable source of information for us. At Children's Hospital, we are quantitating the different B cell populations, including naive B cells, the IgM memory B cells, as well as switched memory B cells. And this is also a fairly straightforward assay that we have at our disposal and helps us in managing these patients. The IgM memory B cells, though, I will mention that they can develop in lymph nodes, so it may not be quite as sensitive as the pit count, but typically patients who are asplenic will have markedly decreased population of IgM positive memory B cells. So we have a fairly standard approach to immunologic assessment of our patients. One, obviously reviewing their medical and surgical history. 2, reviewing their imaging studies to look for the presence or absence of splenic tissue. And then the immunologic assessment really is fairly straightforward. CBC and differential quantitative immunoglobulin assessment, and then, of course, measuring specific antibodies, particularly to pneumococcus, Hib, tetanus, and meningococcus. And this is typically done in slightly older infants who have received at least 2 or 3 immunizations, so we can assess their specific antibody responses. And then, of course, we look at lymphocyte immunophenotyping to look for memory T and B cells and marginal zone B cells. And then we are also looking at RBC pit count. So follow-up really varies a bit from patient to patient, but generally yearly, and that depends on their level of complexity and whether or not any abnormalities were found on their initial immunologic assessments. So I thought it might be helpful to review a case that I'm following currently. So this is a boy who has relatively mild cardiac disease, but has abdominal situs ambiguous and right-sided polysplenia. So his initial evaluation at 3 months showed a mild hypogammaglobulinemia, and I will point out that around 3 to 4 months of age is the time of what we call the physiologic nadir for IgG levels. So that's the time in life where the maternal IgG that's transferred placentally is kind of diminishing, and then the baby's IgG production is starting to ramp off. So that's kind of a nadir for IgG level. We noted that lymphocyte populations were good, maybe even a bit of a lymphocytosis, which may have represented a sort of a reactive condition. But importantly, the RBC pit count in this patient was quite high at 18.2%, which, as we mentioned before, is kind of in the realm of asplenia. So that was a bit of a surprise. Follow-up then at 16 months of life, his immunoglobulin levels had normalized. In terms of his specific antibody production, his Hib titer, the PRP, was protective, but really the pneumococcal titers and meningococcal titers post-immunization weren't that great. So this child, given the fact that he has impaired splenic function and not great specific antibody production, he has been maintained on amoxicillin prophylaxis. And Dr. Wilson is going to go over all the ins and outs of antibiotic prophylaxis following this talk. Also, this patient had an increased population of the unswitched memory B cells, so really some solid evidence that he does not actually have very good splenic function in spite of the presence of a spleen. And then at 23 months of age, more recently, again, his immunoglobulin levels remain within normal range. He received some additional boosters, but still not great titers to pneumococcus or meningococcus. Hib titer, PRP, is still protective, but what was interesting to find is that his RBC pit count had fallen pretty dramatically down to 1.9%, which is getting close to normal range. So this is an interesting finding, and I think one of the questions that we have on our team is, in terms of patients with polysplenia, what is the true incidence of hyposplenism? And we hope to further define that. And then another aspect that would be interesting to follow up on for patients who actually do have hyposplenism, does that improve over time? This observation suggests that that might be the case. So he continues on antibiotic prophylaxis based on this evaluation, and his clinical course has been pretty good. He did have one brief hospitalization this past winter due to fever, and he had a bacteremia rule out. His cultures were negative. He was found to have adenovirus infection. So he has been relatively stable. I'll say that I have had other patients similar to this who, for the first couple years of life, didn't respond well to vaccines, but subsequently, as they got older, around 3 to 4 years of age, they did start to mount meaningful responses to their immunizations, which I think makes their management a lot more straightforward. So these are all issues that I think are worth studying and following sort of longitudinally for these polysplenia patients. Another consideration that we have as immunologists is we heard a lot of really fascinating talks about the surgical repair that these patients go through, and even heart transplants in some of them. What we've observed is that for patients who have undergone heart surgery, particularly early in life, the thymus overlies the heart, and the thymus is a site where T cells, once they exit the bone marrow, they go to the thymus where they get educated in terms of self versus non-self. So with heart surgery, particularly early in life, you remove a lot of that important organ. So what happens is typically you will see decreased number of total T cells, a decrease in naive T cells, and reduced T cell receptor repertoire. So basically, again, just to refresh, the thymus is where naive T cells are educated, and then they go out into the circulation to search for pathogens, and this population of T cells does get reduced. The question is, what is the significance? And I would say the vast majority of these patients are generally healthy, but sort of long-term, as they age, some of the potential late effects of thymectomy include premature immunosenescence of the T cells, and that can be worsened by severe viral infections, which can deplete an already low naive T cell population, and they can also have a slightly increased risk of autoimmunity, neoplasms, and increased infections. So these patients will obviously require closer follow-up and may require additional support beyond antibiotic prophylaxis, perhaps even immunoglobulin replacement if immune function deteriorates significantly over time. Potential interventions for these patients could include trying to minimize thymic removal during their surgical procedures, and consideration of autografts of thymic fragments. Institutions like Duke treat our patients with 22q11 deletion syndrome who have absence of thymus, so they're actually doing thymic transplants where thymus tissue is purified and then surgically implanted into the thigh muscle, and over time develops normal thymic function. So this type of an approach is potentially feasible, just not clinically available at this time. So that is pretty much our standard approach to immunologic assessment, and it's not a one-size-fits-all. As you can see, we have to follow each patient, year to year to make sure that they're having appropriate antibody responses, and we're keeping them as low risk as possible for overwhelming bacterial infections. Thanks for having me.